Today we'll talk about a specific sports traumatology shoulder lesion, that is a slap lesion. We'll see in detail what is a slap tear, how does it origin, which are the features from a clinical point of view, and how to treat it. Good morning everyone, I'm Stefano Teramo and this is OrthoStrike. The name slap tear stands for superior labrum anterior to posterior, and beginning with definition we have to start defining what is labrum and how does it work. Labrum is basically a fibrous circumferential structure that surrounds the glenoid cavity and improves stability of the glenohumeral joint. It's such a shoulder meniscus, we may say, and it helps really the anatomical congruence of the joint, and it's really crucial in improving the stability of the glenohumeral joint. As we know, shoulder is the joint of our body with the higher range of mobility as well as the higher tendency to instability. So a lesion at this level may be crucial and critical in developing a micro-instability chronic pattern which could originate some kind of painful symptomatology. So the slap is the tear of the labrum that localizes itself to the upper portion of the glena at the attachment of the long head of biceps tendon on the upper pole of the glenoid cavity. This kind of injury is typical of throwing sports activities such as in USA, mainly baseball or American football are predisposing athletes to this kind of injury pattern, especially if we think about specific roles such as the pitcher in baseball, who has to make repetitive overhead movements in forced external rotation in order to load the throwing of the ball, and this kind of biomechanical pattern is the crucial lesional aspect that makes easier to develop a slap tear in this kind of sports. If we think about other sports activity, for example volley or water polo or tennis, that may lead to these joint consequences at shoulder, it's really evident as the loading forced external rotation is the biomechanical hotspot in the genesis of this slap tear, because it transmits a biomechanical overload on the long head of biceps, anchor on the upper pole of the glena, and it makes easier to have the degenerative microtraumatism that finally leads to an instability of the anchor of the biceps, and in some cases it could be diagnosed as a slap tear. Talking about classification of slap tears, the most commonly used and widely described in literature is the classification elaborated by Snyder that classifies slap tears in 4 types. The first one, type 1, is the fraying of the superior edge of the upper labrum. Then there is the most common type, that is the type 2, that is a tear of the superior labrum and of the long head of biceps insertion at north pole of the glenoid. Then type 3 is the unstable total tear of the upper labrum with a bucket handle lesion of the labrum. And finally, we can describe a type 4 that is as well an unstable total bucket handle tear of the superior labrum that in this case involves the long head of biceps attachment too. This classification is really crucial because it helps us in deciding the most appropriate treatment indication and then sometimes to decide in which patients to proceed with surgical treatment. We may say that most frequent pattern is the type 2 lesion, and when it happens in a patient really young with no higher age than orientatively 45 years old, it may be suggestible, above all if we're talking about a sportsman or athlete, to recommend surgical procedure in order to repair with arthroscopic technique the superior labrum and the attachment of the long head of biceps. By a clinical point of view, most patients with a slap tear refer some inner pain at glenohumeral region with a painful and soreness that typically develops with overhead movements and sometimes some popping or clicking intraarticularly. By testing clinical exams, we may mention an important test that is the O'Brien's one, that is performed with the upper limb at 90 degrees of elevation and a slight 10 degrees adduction, and then internal rotation with the thumb looking downwards and a resistance opposed by the explorer. In these cases, if the pain is referred by the patient at shoulder region and there is referred relief of the pain with the supination of the forearm, it's really fitting with the probable diagnosis of slap tear, even though it's not just the one clinical sign we may assess, and it's worth to integrate the clinical suspect with a radiological element that's provided us by a specific exam, that is the arthro MRI, arthroscan with contrast, the dye fluid that's able to enhance the sensibility of this exam to almost 90% sensibility in detecting a slap tear. Once assessed the diagnosis of a slap tear at shoulder, it's time to decide the correct treatment. We may say from a general point of view that in case of type 1 or 2 slap tears, it may be worth an attempt of conservative treatment by rehabilitation and muscle strengthening in order to try to achieve a good functional and clinical response. But only in case of patients that present not high sports or functional demand, even though in young patients, when the age is not superior to 45 years, more or less, and above all, if we are talking about sports athletes or professional athletes, in these cases, it's worth to suggest to go directly to surgical option in case of type 2 lesion or in superior grades 3 or 4 times, because in this case it's better, in order to have a shorter time of return to play and a better long-term prognostic, to proceed with a repair by arthroscopy of the attachment of the long head of biceps and the superior labral region. At the same time, if we have a patient that is not young anymore or has not a high demand from a sports or job point of view, it's worth to suggest the possibility to try a muscle strengthening of the scapulohumeral region in order to achieve an improvement of biomechanical stability and a lesser impact of the superior aspect of the glenoid labrum over the biomechanics of glenohumeral joint. Of course, in these cases, it's worth to proceed with the muscle strengthening specific process and rehabilitation protocol during at least 3 months, as we see the fruits of the work and may be able to decide if it's enough to have a good functional recovery, or if not, to decide to make an inversion of the indication and to finally proceed with an arthroscopic surgical repair and post-op rehabilitation. That's all for the moment. I thank you for your attention, and I remind to who may be interested in an online consultation with me that I'm available by Dr. Ale website, and you will easily find the link attached in the description. Thank you, bye bye, and see you soon on AutoStrike.
Come along with me, loving me too, waiting for long tree. I'm waiting for you. There is no choice. Nobody cries too long for me. Sometimes I fall and rise, you know. Some people fly so far with you.